Thank you very much for Boston Scientific giving me this opportunity to present to you. My interest is primarily in severe asthma, and this procedure really does need to be done in a centre where there is expertise in both the assessment and management of severe asthma and the technical bronchoscopic aspects. Now, severe asthma is very complex and heterogeneous, and we need lots of treatments for these patients, and treatments won't help all patients, so careful selection is the key issue. We attempted to understand the complexity and heterogeneity of asthma, severe asthma, using a mathematical technique called cluster analysis, which in a relatively unbiased way looks at how patients cluster together based on a number of key variables. And the severe asthma patients who are shown in this graph in blue had a number of interesting features, but the most striking was that there were groups of patients characterized by a marked discrepancy between symptoms and disordered airway function, shown in this graph on the y-axis, and eosinophilic airway inflammation, shown on the x-axis. And it's the group of patients in the top of this graph who have a lot of symptoms and a lot of airway dysfunction who I intuitively think are those that we should be thinking about a treatment directed at airway smooth muscle. This is an impression. I don't have data, strong data to support it, but all the clinical trials that I'm going to focus on certainly included patients who had a lot of disordered airway function and a lot of symptoms. So that's the group of patients that I have in my mind when I'm assessing patients as potential candidates for bronchial thermoplasty. Now, I was very lucky in the mid-1990s to work with Jerry Cox and John Miller, and I remember having lunch with them one day, and they told me about their plans for bronchial thermoplasty, and I remember thinking that they were a bit crazy, but it is incredible how this procedure has developed. And what they've done is design a logical series of clinical trials, starting in the early 2000s with mild to moderate asthma, and building up to severe asthma, the RISA trial, which I was very involved in, and then finishing with a pivotal and almost unique for a procedure-based process such as this, a sham-controlled study, the AIR2 study. I'm going to hone in on the findings of the RISA study in severe asthma and the AIR2 study, and provide a bit more detail about who was studied and what was found. So these are the patient characteristics, and you will see in the RISA study that the patients had abnormal FEV1, around 65% of predicted, pre-bronchodilator, a lot of symptoms, and they were using a lot of beta-2 agonists. And these patients had very hyper-responsive airways with a geometric mean methacholine PC20 of 0.24 milligrams per mil. So a lot of symptoms and a lot of airway dysfunction. The AIR2 study also included patients with a lot of airway hyperresponsiveness, but they pulled back a bit on the severity of airflow obstruction, with a mean pre-bronchodilator FEV1 of 78% of predicted, and slightly less symptoms. So this was a moderate to severe population. Note also that in both studies, these patients are taking high-intensity inhaled therapy with a combination of high-dose inhaled steroids and long-acting beta agonists. And in the RISA study, a proportion of patients were also receiving oral steroids to achieve some sort of control. This is the RISA study, a small pilot study involving 32 patients, 17 of whom were randomized to no treatment, control, and 15 to bronchial thermoplasty. And these graphs, starting at the top left, show the clinical effects of treatment at 22 weeks and at 52 weeks. And between 22 and 52 weeks, providing certain clinical criteria of asthma control were met, an attempt was made to withdraw oral steroids and inhaled steroids. And more patients in the thermoplasty group than in the control group were able to achieve a reduction in oral steroids and inhaled steroids. So the 52-week data, the patients are not strictly comparable because it's after withdrawal of treatment. So if we focus at 22 weeks therapy, you can see a huge reduction in the number of puffs of beta-2 agonists taken in those patients that were randomized to active treatment. And this amounted to a staggering 7 less canisters per year of beta-2 agonists. If we move over the top on the right, we have pre-bronchodilator FEV1, which improved significantly by about 15% in the group that were randomized to thermoplasty, but not with control. This effect was attenuated by 52 weeks, and there was no effect at any time point on post-bronchodilator FEV1. There were also anticipated improvements in asthma quality of life questionnaire scores and in ACQ scores. The AIR2 study, the sham-controlled study, randomized patients 2-to-1 to active or sham treatment. These patients had 3 bronchoscopies with all the same pre-medication, and they had sham procedures. The investigator who was responsible for obtaining clinical information post-procedure was blind, as was the patient, to what they actually had. This study involved nearly 300 patients recruited from 30 centers in 6 countries. The primary endpoint was the asthma quality of life questionnaire, and data was analyzed for 1 year in the controlled study, but the thermoplasty treated patients were followed up for 5 years to look at effectiveness and safety. The bottom line is that 79% of patients who were treated with bronchial thermoplasty achieved a clinically important improvement in asthma quality of life questionnaire compared to 64% with sham treatment. So quite a big placebo effect, if you like, in this sham-controlled study. This effect was persistent at 6, 9, and 12 months. The most striking finding of this study, which was somewhat unexpected, was the reduction in severe exacerbations, which was significant at 32%, and a large reduction in exacerbations requiring emergency treatment in the ER. A 73% reduction in hospitalization because of asthma-related symptoms, and 66% reduction in days lost from work or school or other daily activities due to asthma. This study provided a huge amount of information on the safety of treatment. 850 bronchoscopies were performed in patients with moderate to severe asthma, and of those 2/3 involved active bronchial thermoplasty. No serious device-related occurrence occurred, so there was no pneumothorax or requirement for intensive care or structural airway problems. More respiratory adverse events were noted in the BT group in the short term, typically within 7 days of the procedure, and the high-risk period being within the day or 2 of the procedure. But these were usually mild and short-lived. These increased adverse events peri-procedure were offset by a reduction in respiratory adverse events after that period in the actively treated group. And we were able to demonstrate, as you've seen already, that the beneficial effects of this treatment were durable beyond 12 months. The RISA study, remember these are patients who had less good lung function and were very symptomatic and using a lot of beta-2 agonists. Here we saw more procedure-related adverse events and more that resulted in hospitalization. But outside the peri-procedure period, the safety signal was generally reassuring. When asked at the end of the sham-controlled study if they would have the treatment again or recommend it to a member of their family or friend, the vast majority answered positively and definitely. So the risk-benefit profile at 1 year is in favor of benefit based on 3 randomized controlled trials, 2 that compared thermoplasty with a no treatment control, and 1 where thermoplasty was compared with a sham-treated control. And at 5 years, the risk-benefit is still in favor of benefit. So why should you consider bronchial thermoplasty for your patients? Well, it's a one-time procedure providing long-term asthma control out to at least 5 years. We've seen maintenance of the reduction in asthma exacerbations and ER visits, and no late respiratory adverse events. And this is data has been accrued from 4 clinical trials, including a large sham-controlled trial. In all studies, there's been an improvement in asthma control, and around 80% respond in terms of a clinically important change in AQLQ. There is some increased short-term benefits, short-term risk, but these are outweighed by the longer-term benefit. So I think it's been proven to be safe and effective in severe asthma phenotype, particularly I think in the high symptom disordered airway function group of patients, and I think should be made available to treat appropriate patients now. So who should you consider for treatment? Well, adults only have been studied. There is no data in children. Severe asthma who remain symptomatic and who have demonstrable abnormal airway function despite high-intensity inhaled treatment. Who meet local criteria for suitability for a bronchoscopy. You should not treat patients who have a pacemaker, an internal defibrillator, or other internal implantable electronic devices. Patients that are known to be sensitive to medications used during bronchoscopy, including lignocaine, atropine, and benzodiazepines. And we have no data on retreatment, so that is not recommended. I'm going to finish by a case report, and this is, I unashamedly show you my best case. This was a difficult patient, a 43-year-old agricultural worker who really had terrible symptoms and a long history of severe asthma. Despite high-intensity combination treatment, he was using up to 1 canister of salbutamol a day, and home peak flow monitoring showed a great deal of peak flow variability, and in the clinic we were able to demonstrate repeatedly bronchodilator reversibility. Interestingly, no active eosinophilic airway inflammation, so this was a guy with very much a symptom-predominant pattern of disease. His airway responsiveness was severely increased, and he had previously, as you would expect in a non-eosinophilic patient, failed to respond to more intense steroid therapy. Now, his response to treatment was nothing short of dramatic. He had greatly reduced symptoms, normal airway responsiveness on at least one occasion. This picture is taken from the local newspaper. His great ambition in life was to participate in a race between two villages in Leicestershire, where the winning team finds a cask of beer and brings it back to their village. And there are no holes barred, fighting anything. And this is, as you find in rural England, one of the traditional annual events. And Donald was never able to participate in this event, but on this occasion, not only did he participate, but he won in that he found the cask of beer. Thank you very much.